Welcome back, guys. We're back in the neurology section, and we're now going to start talking about the management of different types of um, of medical or the neurological emergencies. And obviously, when you think of a neurologic emergency, what you're really the big one that you actually think of is your stroke patients. But there are other things other than strokes that can cause neurologic problems, so we need to make sure that we understand it. All right, so the primary treatment for the nervous system emergencies in the field, again, airway, 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 breathing, breathing, breathing. If we have neurologic control disruption, we need to make sure that A and B is working. We need to make sure that the lack of C is not causing our problems, okay? Again, can we use pharmacological interventions and psychological support? Absolutely. And treatment considerations, okay? So as we're doing this, again, these are things that can cause any type of neurologic problems. And the mnemonic that we use is AEIOU tips, okay? And obviously they stand for different things. The A, of course, is acidosis or alcohol. E is for epilepsy. I is for some sort of infection process. O is for overdose. U stands for uremia, which means kidney failure. Again, TIPS is either trauma, tumors, or toxins. I is your insulin, whether it be high or low sugar. P is a psychosis or a poison. Kind of goes back to that toxin thing. Notice how that's kind of in there both times. And then S would be your stroke or your seizure. So all of these things, if you can stop and think about it, can cause altered mental status. So start going through your AEIOU tips if you've got somebody who has altered mental status. All right. Determine the underlying cause. Yeah, imagine that. It gets a lot easier to treat. Okay, again, I would say make sure that we assure that the ABCs are present as well. And make sure your C-spine is there and get the circulatory status. Get your IV started, obviously. And I would get a blood glucose, okay? You guys are, again, we kind of drilled that into you guys in the first 2 semesters. Even more important, because there is nothing more, calling a stroke alert with a blood sugar of 20 is a really bad day for you, okay? So don't forget the basics here. If you think that it's a narcotic overdose, of course, we've been handing out Narcan last couple of years like it's candy. But unfortunately, yeah, we have a narcotic epidemic, which is causing that. And if they're a suspected alcoholic, remember the 100 milligrams of thiamine, or they're malnourished. That's another one. All right. So again, Wernicke syndrome. We talked about that a little bit on the last video, but it's an acute but reversible encephalopathy. It's caused by, again, a lack of thiamine. Okay. So that's what we're trying to prevent. Now, Korsakoff psychosis, again, in memory disorders, and it may be irreversible. So yes, they can actually get this, especially with your chronic alcohol patient. Okay. So again, your altered mental status, again, if you got an increase in intracranial pressure, these are the guys that you want to ventilate. You want to keep their CO2 around the 30 level, okay? 30 to 35 is your magic number there, okay? So it's a very short-term Band-Aid for increased intracranial pressure. What it causes is it causes cerebrovasoconstriction. And there's a little bit of a trade-off, but if you've got really good cerebral perfusion, you should be okay in a short-term situation, okay? Mannitol, again, that's an osmotic diuretic, and it can cause diuresis. This is kind of an old-school thing, but yes, they use mannitol to take fluid off of the brain. And then as with all medications, again, we're going to continue to follow our local protocol. I will tell you mannitol is not part of any one that I know of in Florida, but I'm sure there are places that they do have it. So again, stroke. What is a stroke? It's some sort of problem with blood flow to the brain, cerebral blood flow, okay? And it is so crucial because, again, early detection of this is what's going to make the difference between that person walking out being normal and that person being permanently paralyzed or dead, okay? And it's in stroke care. When I first started in this business, guys, if you had a stroke, that was it. Yep, you're going to be in a nursing home probably the rest of your life. Nowadays, people are walking out of hospitals because of a thrombolytic stroke. And we got to understand that there are different types of strokes. There's a clot stroke, there is a thrombus stroke, again, so whether it be an embolotic or a thrombus that's causing blood flow stoppage in the brain versus actual intracranial hemorrhage, okay? By the way, two very different forms of treatment, okay? So clots, we usually go in and we break those clots up using TPA. Intracranial hemorrhage, if we give them TPA, they will die, okay? So one of the things you're going to see a lot of, especially like during your ACLS, and we talked about the stroke video, and they talked about that there is a small chance, but if we give you this drug, you might die, which is why getting them into a CAT scanner is so important, because if they're bleeding in their brain, we can see that on the CAT scan. We can't see the blockages on a CAT scan. That usually requires an MRI, okay? So again, but we can tell if they're bleeding or not, and that's the key thing, all right? And again, it's a life-threatening problem. So again, your occlusive stroke is when you got a cerebral artery blocked or clogged by other foreign material. By the way, our AFibers like to throw that material up and through the heart, goes up into the brain, gets clotted in there, okay? So that usually progresses to infarction and then the death of the tissue, all right? So again, back to that thing of, we talked about it in heart attacks about the penumbra. We want the blood pressure being high in these patients is actually, for a thrombolytic stroke, not necessarily a horrible thing, because what it does is it increases the collateral circulation. Again, if you have an intracranial hemorrhage, it's a really bad thing, and the reason is because more blood's being pumped up there, and again, more blood's going to be squirting out whatever hole whatever the bleed is, more blood's going to be shooting out of it. All right. So again, a lot of the times strokes are, again, infarction strokes, but 15% of them are hemorrhagic, okay? The major causes of these guys is usually some sort of atherosclerosis or a cardiogenic embolization. Again, AFib, they start throwing the little microclots as they start going in and out of AFib. And then there can be other causes for that, weakening of the vessels, actual brain bleeds, trauma can also cause this. So again, your embolotic stroke is there's a solid liquid or gas mass that's carried from the vessels at a remote site. And these guys are usually thromboectoli, and it's derived from diseased blood vessels in the neck. And it usually goes to the cardiac chamber of the heart. And then again, other types of emboli, this is actually the one my mom ended up having a stroke from, was she had a artificial heart valve installed. It began to grow vegetation. The vegetation broke off and actually went to her brain. Okay. So that would be an example of an embolic stroke. Okay. Now, your thrombolytic strokes, again, is a cerebral thrombus of the blood clot. It's actually developed in and it obstructs the cerebral arteries. Okay. So again, just like your heart, you can have atherosclerosis in the brain, okay? So when somebody has coronary artery disease, they more than likely probably have it in their other vessels as well, okay? So usually the strokes, they can occur at night, and we don't really know when it happened, but as the deal with stroke management is to identify the last time that we saw them normal, and for the best possible return of function, okay? And again, most of us, when we assess these folks, we're using the Cincinnati Pre-Hospital Scale. Again, we're checking for arm drift, we're checking for your facial droop, arm drift, and then your speech pattern. By the way, there is a very specific reason why we use the phrase "you can't teach an old dog new tricks." There is an extremely specific reason that we use that, because it uses different vowels and consonants to use the different cranial nerves of the face. P.S. Know your cranial nerves. And that's why we have them say that particular phrase. It requires different nerves in order to function, in order to make those sounds, okay? It's usually often and sudden. It's usually, by the way, marked with a severe headache. Matter of fact, one of the very typical strokes, a brainstem stroke, they'll actually say, "I've got the worst headache of my life," or it felt like a thunderclap. And when their patient is saying that to you, that is by the way, a really, really, really bad sign. Okay. So most intracranial hemorrhages is due to the hypertensive patient, where you get the small blood vessel breaks, and then the subarachnoid hemorrhages results from a congenital blood vessel abnormality or some sort of head trauma. Okay, so this is what we're talking about when we're dealing with our strokes, the different types of clots that can happen. All right, so again, assessment of these patients: facial droop, all right, headache, confusion, agitation, dysphagia, saying, not being able to say the right things, aphasia, not able to speak at all, dysarthria, slurring of the words. Okay, make sure that you know what all of these words mean. All right, make sure they're saying the wrong words. Okay, if I pick up this pen and I go, I want the ball, I want the ball. This is a pen. Okay, but to that person, they're thinking, they're because of the translation in their brain, they think that this is the ball. Okay, even though they know it's a pen, they'll keep saying it's a ball. Okay, that would be a good example of speech problems that usually happens. Again, vision problems, by the way, you can actually be, with certain types of strokes, blind and completely unaware that you have a left side of your body. Okay, you can be paralyzed on one side or the other. You can be paralyzed in the upper or lower. You feel tingling or pain, and then inability to recognize touch. Okay, that's why we do those sensory, and that's why when I teach you guys the MEND exam in class, that you guys will see what's going on with that. So again, things that leads us to think that it might be a stroke: hypertension, diabetes, abnormal lipid values. They got a high triglycerides, high cholesterol. If they use oral contraceptives, they are more prone to having a stroke. Sickle cell disease, again, the sickle cell actually kind of forms a thrombus. Okay, and then some cardiac arrhythmias. Again, AFib is our big one, especially new onset of AFib. Now, how do we actually, there's several scales. Los Angeles, again, it tests all these things, but the one that we normally do, of course, is the Cincinnati Pre-Hospital Scale, which is your, again, facial droop, arm drift, and again, and then you can't teach an old dog new tricks. Okay, so those are the three things that we test. By the way, that's the actual start of the MEND exam, which is the thing I'm going to teach you again in class. All right, so your TIAs. Mini strokes, all right, temporary interference in the blood that they usually cures itself. The big thing about a TIA, usually within 72 hours to 1 week, they will end up having a stroke if they do not receive treatment. Okay, and a lot of times you're going to get there and this patient's going to be full on stroke alert, and then literally 30 minutes on the way to the hospital, all of a sudden they quickly resolve. It's not to say that these guys aren't in trouble. They are. Okay, they run a very significant risk of having a stroke. Okay, so you need to make sure, even if the symptoms resolve, okay, make sure that you, and if they do resolve, make sure that you note the time that it did resolve, and make sure that you understand, and make sure that you properly relay this to the physician, because that's the one that you get there and he's like, seriously, doc, this patient was, a few minutes ago. And that's not the case. All right. So again, these are high risk. The onset is usually abrupt, and actually the resolution usually happens pretty quickly. Okay. So again, same kind of things for a stroke. You're going to end up with the TIA, and again, watch that. And if they have palpitations or they got a history of hypertension, cardiac disease, all of these are usually precursors that add to them having a TIA. Now, how do we care for a stroke? I think that this was kind of number one: get them to a CAT scanner. Period. All right? If you have one goal in life, that's your goal. Get them to a CAT scanner. Time is brain. All right? If it is a thrombolytic stroke, the faster that we get our clot-busting medicines and restore blood flow, the faster that the faster that they're going to recover. Okay? If it's an intracranial hemorrhage, they've got to get to a neurosurgeon to go in there and either A, fix it, or B, prevent the intracranial swelling. Okay? So early recognition, again, you got to identify it. All right? Supportive measures, rapid transport. Do I need to over-oxygenate these patients? No. Keep their O2 sat 94 to 99. 2 liters via nasal cannula is fine, okay? There is no reason to super over-oxygenate this patient. O2 sat 94 to 99. Let the emergency department go and make sure you take them somewhere with a CAT scanner. Take them somewhere where they can actually be fixed. God, I can't stress that enough, okay? Again, if I have a stroke center in the general area, I need to go to that stroke center. It might be 2 to 3 minutes farther to go. Take them somewhere where they can be fixed, okay? I can't stress that enough. Well, we took them to the freestanding because we need to get a CAT scan. Yeah, until they need a brain surgeon, okay? There's no brain surgeons at the freestandings, okay? Take them where they can be fixed, all right? So know where your stroke centers are. I'm talking not only primary stroke centers, but comprehensive stroke centers. And by the way, if I'm having a stroke, don't take me to a primary center. Take me to a comprehensive center. The comprehensive centers are designed to specifically treat stroke patients, along with the post-care that's needed after the initial event, okay? Again, scene safety, get your IV. Remember, these patients might have personality or mood swings or changes, so be acutely aware of that, okay? And make sure that you maintain your safety with that. Ventilation rate, 10 to 12 a minute. Check for hypoxia. Check your blood glucose, okay? Make sure, and the saline lock. Guys, you don't have to start flowing fluids on these guys. TKO is fine. Maybe I would get a second line if I think that it is a true stroke alert, because they're going to need more than one port to get into these patients, okay? Again, they're going to monitor, they're going to protect paralyzed extremities. Again, remember, they are floppy, they are flaccid, they can't feel things, okay? Give the patient reassurance. Folks, these guys can usually, if they can't talk or they're talking the wrong way, they can still usually understand you, okay? And tell them that. Say, look, I know what you're saying to me are the wrong words. I know that you're trying to say the right things. It's okay. You keep talking. That's a perfectly acceptable thing to do. Matter of fact, you want them to do that, okay? So again, understand, if they can't talk, that doesn't mean that they don't understand you, okay? So again, a good quality, and make sure that you continue to talk to those patients. All right, now we're going to hold up on the seizure there, and we're going to talk about that one on the next pass here. And I'll see you guys on the next one.